Hello, this is Dallin from the Hardy Nutritional Science team. Today I want to talk to you about a study that was published in 2010 in which autistic patients were given either vitamins and minerals or psychiatric drugs, and the outcomes between those two groups were compared. The psychiatric symptoms which accompany autistic disorder may actually be the result of dysfunctional or slowed metabolic activity, and this results in a lack of food for the brain as well as the inability to eliminate metabolic waste and toxins efficiently. And these issues both likely increase the demand for micronutrient cofactors, or in other words, the essential vitamins and minerals. Improved metabolic efficiency is one of several mechanisms that have been proposed to explain how broad-spectrum micronutrients affect brain function. Among other things, essential nutrients upregulate the efficiency and capacity of both neurotransmission and mitochondrial energy production. This study took advantage of pre-existing parental preferences, either to use primarily micronutrient supplements or primarily drugs for autism treatment at a private clinic. Over the study period, the attending psychiatrist did his best to treat all his patients according to parental preference, and so some children received primarily alternative therapies and supplements, while others were given conventional psychopharmacological treatment using prescription drugs. This created an ideal situation for comparing the two different styles of disease management in a natural clinical setting. And at the time of referral, all met the diagnostic criteria for autism disorder, including tantrums, aggression, and self-injurious behavior, or a combination of these problems on top of the base diagnostic criteria. Assessments were taken of patient history, physical examinations, blood work were completed, as well as an MRI or CT scan of each child's brain, and then behavioral symptoms were repeatedly assessed by multiple raters using standardized measures. 44 pairs of otherwise similar patients who differed in their treatment approach were retrospectively identified from 10 years of patient records. So there was 44 using micronutrients and 44 using prescription drugs, 88 in total. And they were statistically evaluated using matched pairs analysis. So each patient was matched with another similar patient having the different primary treatment. Both groups were evaluated using the same standardized outcome measures, and all were treated for at least 3 months. Results showed that it was possible to achieve comparable overall symptom management with both micronutrients and pharmaceuticals. For instance, the overall score improved significantly for both groups on the Childhood Autism Rating Scale and the Children's Psychiatric Rating Scale. However, micronutrient-focused care outperformed conventional psychopharmacological treatment on the psychiatrist's overall impression of improvement and in many other significant ways. For instance, although the behavior problems of both groups improved, the scores of the micronutrient group improved significantly more on the aberrant behavior checklist. And micronutrient management resulted in the following additional significant advantages: lower activity level, less social withdrawal, less anger, better spontaneity in relation to the examiner, less irritability, lower intensity of self-injurious behavior, and markedly fewer adverse events, including significantly fewer gastrointestinal and musculoskeletal issues, less anxiety, less fatigue, and less weight gain. The number of adverse events clearly correlated with medication use. Over the course of treatment, the number of medications prescribed was dramatically decreased in the micronutrient group, but it increased in the group preferring psychiatric drugs, which makes some sense. In all cases, the psychiatrist's goal in managing the medication was to find the minimum dose that would bring symptoms to acceptable levels and also maintain an acceptable side effect profile. There were only 3 advantages to medication management that were identified, and none were related to symptoms. They were insurance coverage, fewer pills, and less frequent dosing. Now, although this study does not carry the weight of an RCT, a randomized controlled trial, case control studies like this with patients from medical practice can be very instructive about whether or not a particular approach is promising. And importantly, the features of RCTs which limit their generalization to clinical settings did not plague this data set because it was collected directly from active clinical practice. For instance, it's not unusual to read an RCT that excluded candidates who ever considered suicide, had multiple diagnoses, were using a benzodiazepine or some other drug that was excluded, abusing substances, recreational substances, and such inclusion criteria would exclude the majority of patients typically seen in a clinical practice. Thus, many RCTs, depending on their inclusion criteria, can answer questions about efficacy only in relation to placebo or other medication. They cannot really answer questions about effectiveness in actual practice. It has been said that if we want more evidence-based practice, we need more practice-based evidence, and this analysis addressed the question of the effectiveness of broad-spectrum micronutrients in autistic patients in a realistic and practical setting. And the results were incredible. They definitely warrant further consideration and exploration.